Okay, so good afternoon, everyone. Here we are again gathered to celebrate World Physiotherapy Day, and the AIMS has organized CME, and the series of CME organized by AIMS, and we are today going to witness the first episode of the CME. And the speaker for today is Dr. Varoon sir. So, Alpa madam, I am asking you to please give a brief introduction about the sir, and then we can start with the CME for today. Alpa ma'am,
Okay.
over.
Thank you, Hardini madam. So good afternoon all my dear students and respected faculties. Heartily welcome Dr. Varoon sir in Ahmedabad Institute of Medical Sciences. I am here to share a brief introduction about the Varoon sir. Varoon sir completed his Bachelor of Physiotherapy from the MUHS and Master of Physiotherapy in Cardiovascular and Respiratory Physiotherapy in 2009. Currently, he is pursuing PhD from the Sumandeep Vidyapeeth, Vadodara. His special interest in exercise prescription to the special population like diabetes, hypertensive, ischemic heart disease, congestive cardiac failure. He has presented many papers in various conferences. Currently, he is working as a professor at MAEER'S Physiotherapy College, Talegaon, Pune. So today, sir is going to share his expertise vision on an art of exercise prescription in cardiopulmonary conditions and evidence-based approach. So thank you, sir. Welcome you, sir. And over to you, sir.
Thank you, Alapa ma'am, for the wonderful introduction. I hope I'm audible.
Yes, sir. Audible.
Can you please give me permission to start my video? Yeah, I think I'm able to now. So very good afternoon to one and all present here. And I extend my warm greetings to all the wonderful physiotherapists on a World Physiotherapy Day. So as I really want to congratulate Ahmedabad Institute of Medical Sciences for organizing a CME on the topic exercise prescription, because it is the need of an hour. And to start with, I would like to say, I'll just share my screen first. Yes. I hope the screen is visible.
Yes, sir.
Yes. So cardiovascular and pulmonary conditions is the leading cause of death and disability globally. And I am very sad to say that India is leading in this race of disability and death. We have maximum numbers of deaths because of cardiovascular and pulmonary conditions in the world, and so as the disability. So we as a physiotherapist play a major role in reducing the disability and also the mortality in these conditions. And it has been long proven that we have a major role to play, but this coronavirus pandemic has brought our profession into the spotlight. So let's take this opportunity, and we should reduce the disability and mortality globally. And I really want to thank Ahmedabad Institute of Medical Sciences to give me this platform to share my knowledge. So let's get started. First, as the topic says that it is an evidence-based approach, let's discuss few researches which proves that we have a major role to play in reducing the disability and mortality in cardiopulmonary diseases. So it all started with this paper published by Morris et al. 40 years ago. He reported that middle-aged men perform vigorous physical activity in their leisure time on at least 2 days a week have 1/3 lower likelihood of developing coronary artery disease than their inactive peers. So those who are sedentary lifestyle, or those who are not participating in any kind of exercises, okay, they are more prone to coronary artery diseases. These were proven 40 years ago. This outstanding scientific work on physical activity in coronary artery disease by Morris et al. greatly stimulated further research in this field. So we are going to discuss few of the evidence which proves that exercises are really important in improving or reducing the mortality and improving the disability in coronary artery disease or cardiopulmonary disease. Okay. Someone please, whoever mic is on, please switch off the mic. There's a lot of disturbance coming in. Okay. Then come the recent systematic review. Okay, this is a systematic review of systematic review. So very robust evidence given by Warburton and Burden, and they have given this from 16 systematic review and meta-analysis, one study of 16 studies. Okay, that the relationship between the physical activity and health benefit is curvilinear, which means that the greatest benefit appear at the minor volumes of physical activity. So we should not give more physical activity or more exercise prescription. Just a simple physical activity program can reduce the mortality and disability in the patients with cardiopulmonary disease. So we have to just stimulate our patients or the patients with cardiopulmonary disease to exercise a bit, and it will greatly reduce their chances of morbidity and mortality due to cardiopulmonary disease. And high volumes of physical activity or high volumes of exercise prescription are dangerous. That's what they have said. And if you all see, this review has been published in year 2017. So this is the most recent evidence what I'm sharing with you guys. Okay, so we have to just increase the level of physical activity by our exercise prescription. We don't have to give an humongous amount or volume of exercise which can have a catastrophic event. Okay, so again, a meta-analysis of 8,940 patients who had either experienced myocardial infarction, gone under a revascularization surgery, or complained of angina, or had documented coronary artery disease by angiography. From 48 studies revealed decline in total and cardiovascular mortality by 20 and 26% respectively. So there is a good amount of evidence which is, and other than cardiovascular disease, the multiple morbidity patients like those who have osteoarthritis, hypertension, type 2 diabetes, depression, heart failure, ischemic heart disease, and chronic obstructive pulmonary disease. This systematic review of randomized control trial, which is considered to be the highest quality of evidence. Okay, this is evidence-based era of evidence-based practice. We cannot say anything without the research. Okay, so the exercise therapy appears to be safe. They have concluded this. The exercise therapy appears to be safe and to have beneficial effect on physical, psychological health in people with multi-morbidity. So the exercise is beneficial in not only in cardiopulmonary, but also for diabetes, hypertension, depression, heart failure, and osteoarthritis. Okay. So these are all the evidence what I wanted. These are just few evidence. There are number of studies which has been published in high quality journals which says that exercise prescription is beneficial, provided it should be prescribed scientifically. Okay, so coming to exercise prescription. So exercise prescription, what we have just discussed, there is indisputable evidence exists that exercise are beneficial for patients with cardiopulmonary diseases. Okay, so we have to ensure, we as a physiotherapist have to ensure that exercise should be beneficial to the patient population. Why? Because if we give a very low intensity exercise, there will be no effect of exercise. And if we give very high intensity exercise, there could be deleterious effects of exercise or exercise related complications. So the appropriate training threshold stimulus should be prescribed by appropriately assessing the patient by performing a submaximal exercise test, and based on that exercise test you have to perform or to prescribe therapeutic exercise. So assessment is very important here. So before going to the assessment, let's see what happens when a patient of a coronary diagnosed or the patient suffers from a coronary artery disease. So what you can see here is a nitrous oxide, which is a potent vasodilator, and it helps in the blood flow in the coronary artery disease. So because of the endothelial dysfunction, which is the innermost layer of the arteries, so there is endothelial dysfunction when the patient suffers from coronary artery disease. Okay, so the nitrous oxide production goes down and the nitrous oxide inactivation, okay, it is increased. So this causes reduction in the coronary artery blood flow. This is the major pathophysiology of ischemia in the cardiovascular diseases. So, but with exercise, we can achieve partial correction of the endothelial dysfunction. And this has been I have taken from the recent review, contemporary review of American Heart Association. Okay, so again, there is a research backing this, whatever I'm saying. Okay, so nitric oxide production is improved and the inactivation is reduced with the help of exercises or therapeutic exercise, provided we give proper stimulus, proper threshold intensity of exercise. The intensity what we prescribe, intensity is one of the characteristics of exercise prescription. Okay, there is mode, intensity, frequency, and duration. There are 4 characteristics, okay, or 4 components of exercise prescription. So intensity is one of the most important component of exercise prescription. So if you give proper intensity or threshold intensity of exercise, then definitely there is partial correction in the endothelial dysfunction. There are many more to come. And if you can see in this figure, there is opening of the collateral, there is increase in the size of the lumen, and also there is angiogenesis. The new blood vessel has been formed, okay, with the effects of exercise. So the patient will definitely have improved functional capacity, okay, once they are well trained or they continue to do exercise under the supervision of a physiotherapist or exercise prescribed by a physiotherapist. Okay, so as I said, there is partial correction of the endothelial dysfunction, there is formation of the collaterals, there is regression of the coronary stenosis. So there is a trial, lifestyle heart trial, which says that multifactorial intervention lasting for a year that included 3 hours of exercise training per week induced 3.1% regression in the coronary stenosis that was associated with decline in cardiovascular event rates. So this is very important that we can be useful in regression of the coronary stenosis also. Okay. So before we get on to how to prescribe, today's webinar is going to be very practical. We read a lot about exercise prescription and but we end up just advising simple walking to our patients. But today in this webinar, I'm going to make sure that all of you will be able to prescribe proper scientific exercise protocol to all your patients based on your assessment. Okay, so the first thing what you should, I think we all know this, but we need to explain these to our patients. So whenever you encounter a patient of diabetes or say hypertension or coronary artery disease or COPD, and we tell them that exercises are very important, the global reply or the common reply what we get is, okay, we do exercise, we do a lot of work, and that is the exercise for us, and we go for walking daily. So these are the replies we get, and we just say, okay, they are exercising. So what is new what we are going to do? So here we need to tell them that the physical activity, whatever you are doing is physical activity. And there is a difference between physical activity and exercise or therapeutic exercise or a structured exercise. So the physical activity refers to the contraction of the skeletal muscle that produces bodily movement and requires energy. So whatever your patients or patient says that we are already exercising, we are doing household work, I'm climbing stairs, I'm going for a walk. So that is the physical activity. And that is also important. But along with that, you have to do exercises or therapeutic exercises. So the therapeutic exercises or exercises is a physical activity that is planned and is performed with a goal to attain or to maintain physical fitness. Okay, so we need to tell them that the exercises what a physiotherapist or you as a healthcare practitioner you're going to prescribe them is the goal is to maintain the physical fitness or to improve the physical fitness, and it will be planned and it will be structured, and its effects will be more than that of the physical activity. Okay, so the person needs to be physically active as well as he has to do a structured exercise program prescribed by a physiotherapist. So this is very important. You need to tell this to your patient on the very first day of the consultation. Otherwise, they don't take us seriously, and what they think is, I'm already doing exercise and this doctor is going to again teach me some exercise. So you need to drill this into their mind that whatever you're doing is correct, but we need to add on to this to gain more and more benefits. The simple example what you can take is, you can just take a survey amongst your relatives or friends who are suffering from diabetes and hypertension. All of them, they are doing exercise, but their diabetes is not under control. You will find maximum of them, their diabetes is not, just because they are not achieving a threshold intensity of exercise prescribed by a physiotherapist. So intensity is very important tool in prescribing an exercise. Okay. So the exercise prescription, as I said, exercise prescription is scientific method of prescribing therapeutic exercise, which is based on evaluation of the exercise capacity of an individual. So it has to be separate or different from different individual. It is individually tailored and it is always graded. You don't have to tell the patient that from next day you're going to walk 5 kilometers or next day you're going to walk for 3 kilometers and do some gym. So that is not how it works, because they will default on their exercise program. They will never be adherent to their exercise program. It is always graded. You have to tell them based on their exercise capacity, you keep on walking slowly, and based on your box scale, based on your exertion, it has to be graded. Okay, so to cut the long story short, the exercise has to start slowly and gradually it has to be progressed. Okay, and it has to be based on principles of exercise prescription, that is overload, specificity, and reversibility. So we need to give overload, and that overload should be systematic. And remember, we are dealing with cardiopulmonary patients. If we don't give systematic overload or we give a lot of overload, they can end up with a cardiopulmonary event. Okay, so the overload has to be very gradual, graded, and safe. Okay, specificity. Definitely, if you want to increase that exercise tolerance in cycling, the mode has to be cycling. If you want to increase the exercise tolerance in walking, the mode has to be walking. And you need to tell them reversibility. If they stop exercising, then these effects are going to reverse back and they are again going to land up with morbidity or disability. Okay, so these are the basic principles. I hope we all know this. I just wanted to emphasize this, that overload prescription should be graded and safe. Okay, so which condition? So here in short, I just want to tell that any cardiopulmonary condition affecting the oxygen transport system of the human body. So here, if you see, the oxygen we start inhaling from our nose and it goes into the lung, and then from lung the blood gets oxygenated and it goes to the heart, then it gets circulated to the entire body with the help of your blood, and then it goes to the muscle and the muscle contract. So this is the oxygen transport system of our body. Anywhere it gets affected, okay, our role plays, except anemia. Okay, anemia is a physiological problem. We cannot help much because there is some problem in the RBCs or hemoglobin. So the oxygen cannot be transported physiologically. Otherwise, we have a role in every system where the oxygen transport is disrupted. Okay, so pulmonary system, we have diseases like COPD, or recently we have seen the pandemic of COVID-19. Okay, which affects the parenchyma of the lung or causes ARDS. And then the cardiovascular system, the coronary artery disease, the congestive cardiac failure, the chronic kidney disease, also we have a big role to play there. Okay, and the muscles, where we change the muscle biochemistry of aerobic fibers and anaerobic fibers. Okay, so all this is the oxygen transport system where our exercise prescription will have the effect on, and it will enhance the oxygen transport system, thereby increasing the exercise tolerance or exercise capacity of the patient and reducing the disability and improving the functional capacity of the patients. Okay. So whenever the patient will come to your clinic or for the consultation, a brief medical history is very important. We need to know what he is suffering from, or for what disease he is suffering from, and what medications he is on. And it is very important for us to know, because the medications will affect the exercise capacity and also the monitoring level of our management. Okay, that is why the medical history is very important. Then family history, if any patient is having any family history of cardiovascular and pulmonary disease, because this will affect the monitoring level, or the patient falls into a high risk category. Okay, then the exercise history, you need to know how much your patient is exercise, how sedentary he is. Okay, so that is also very important. Risk factors, just not for documentation, but you have to note down all the modifiable and non-modifiable risk factors for risk stratification. You need to stratify the risk of the patient, whether your patient falls into a low risk category, a moderate risk category, or a high risk category. So based on this risk categories, you are going to prescribe the intensity. You are going to monitor the patient. Okay, so risk factors, noting down of the risk factors are very important. And recently we all have seen the role of oxygen saturation. Okay, so oxygen saturation should be noted down at rest and during the activity, that is the exercise test you are going to perform. Okay, and as I said, risk stratification, low, moderate, and high, you have to put the patient in that category, and also perform a submaximal exercise tolerance test. So these 7 elements of assessment are very important: medical history, family history, exercise history, risk factors, oxygen saturation at rest and activity, risk stratification, and submaximal exercise test. We are going to discuss all these in detail. Okay, because based on these assessment only, we are going to plan out our exercise program. Okay, so medical history, as I said, history of any medical condition you're suffering from, your patient is suffering from, kind of COPD, ischemic heart disease. So what is the extent of that medical condition, for how many years he is suffering from? That is very important to be noted down, because it will help you in planning the exercise. Or also in any contraindication to exercise stitching or prescription, whether your patient is suffering from aortic stenosis or uncontrolled hypertension and diabetes, or both. So these become the contraindication. You have to screen the patient first for the contraindication to avoid the untoward events or catastrophic event before starting the exercise prescription. Also, the existing and the past medical management, whether your patient is on beta blockers, bronchodilators, because these are going to affect your exercise program. Okay, so we are going to, if the patient is on beta blocker, then you cannot monitor the exercise heart rate or the heart rate of the patient during the exercise, because the beta blocker will blunt the heart rate response of the patient. Similarly, the bronchodilators, if the patient is on bronchodilator, then you need to ask your patient to take the bronchodilator before your exercise program. Otherwise, he may land up into bronchospasm if he is a patient of COPD or bronchial asthma. Okay, so the medical history plays a very important role whenever you want to prescribe a exercise prescription to the patient. Okay, the family history and the exercise history. The family history of a cardiovascular pulmonary disease, you need to note down history of a sudden cardiovascular death in the family, premature cardiovascular disease. For example, patient says that someone or his blood relative or his parent has suffered a cardiovascular disease prematurely, that is in the age of 40s or 30s. Okay, so that gives you a bell should ring that this particular patient may have a higher risk. Okay, and then you need to plan out the exercise program accordingly. Then the intensity needs to be lower down. Okay, and the monitoring has to be increased. Okay, so these points have to be noted down: the family history of diabetes and hypertension. Okay, exercise habits of the patient, whether he is doing some exercise or he's not doing, or he's just sedentary. If you take history of a few of these patients, you will find they are not actually walking. They are just getting down from the elevator from the building, sitting inside the car, reaching their office, take another elevator, sit for 7 hours, again go back, take the elevator and take the car and come back. So remember, you all should know, sitting is the new smoking. If you are sitting for around 6 hours a day, you are it is equivalent to smoking a 1 packet of cigarette. Okay, so sitting is so bad. So you need to note down how sedentary they are, and again, you need to be very gradual in increasing their physical activity. Please switch off your mic. A lot of disturbance. Please switch off the mic. Risk factors. Okay, we all know, we all have read this in third year, modifiable and non-modifiable risk factors. We need to note down this because it can also act as an outcome measure, and also it will guide you in your exercise prescription. If the patient is suffering from hypertension, diabetes mellitus, sedentary lifestyle, obesity, smoking, dyslipidemia, okay, you can always check after 1 month of your exercise program how you have modified this risk factors. That is why it is important to note down these risk factors. Okay, also the non-modifiable family history, age and gender are very important for you to note down, because you have to classify the patient or stratify the patient into low, moderate and high risk. Okay, so let's come to the risk stratification. So these are the characteristics of a patient who is in low risk. Okay, so if there should be an absence of complex ventricular dysarrhythmia in the ECG, or during the exercise tolerance test, or during the recovery. Okay, the ECG has to be normal. There should be no angina or other significant symptoms like unusual shortness of breath, lightheadedness, dizziness or heart rate and systolic blood pressure will increase workload and recovery. Okay, so abnormal response of heart rate and systolic blood pressure during the increasing workload and recovery. So these all this should be absent, and there should be presence of normal hemodynamic response during the exercise testing and recovery. So the normal means appropriate increase in or decrease in the heart rate and systolic blood pressure with increasing amount of workload and recovery. So what I mean by here is, for example, you are increasing the intensity of the exercise and there is a drop in the heart rate or drop in the systolic blood pressure. That doesn't go along with a normal physiological response. Okay, that should not be there. What should be there? With increasing intensity of the exercise, there is increase in the heart rate and the systolic blood pressure. And also during the recovery, the heart rate should drop and the systolic blood pressure should drop. Okay, it should not happen so during the recovery, the systolic blood pressure is not dropping or it is taking longer duration of time to drop, or similarly with the heart rate. Heart rate is the first thing to drop once you stop the exercise. Okay, that is the reason we take first, we record heart rate in an exercise tolerance test. Okay, the functional capacity should be more than 7 minutes, means the second stage of Bruce protocol. The patient should have crossed the second stage of Bruce protocol for you to categorize, and all this with all these parameters for you to categorize them into low risk. That to cut the long story short, just say if the patient has crossed the second stage of Bruce protocol with normal hemodynamic parameters, then you definitely categorize the patient into low risk. Okay. So these are exercise testing findings. If you don't have exercise testing report, then how would you classify? So there are certain non-exercise testing findings. Okay, so ejection fraction more than 50% in echocardiography at rest. Okay, uncomplicated MI or revascularization procedure. What do you mean by uncomplicated MI? Patient has suffered an MI, he got hospitalized, he got thrombolized, and he's back. There was no complication during his MI. So that is uncomplicated MI. And the revascularization was done properly, and there was no complication during the revascularization. Okay, so absence of complicated ventricular arrhythmias at rest, or the ECG is normal. Absence of congestive cardiac failure, that means no breathlessness at rest, no pedal edema. Okay, presence of signs of symptoms post event or post procedure ischemia. Absence of signs of symptoms post event or post procedure ischemia. So there should not be any ST segment depression, okay, or absence of clinical depression. So all these things when you see, okay, then the patients are in the low risk category. It is very important for you to do risk stratification before you give any exercise program. Okay, so then comes the moderate risk. So again, presence of angina or other significant symptoms. Okay, if the and the exercise capacity of less than 7 minutes. Earlier in low risk, it is more than 7 minutes. Now it is less than 7 minutes. Okay, mild to moderate level of silent ischemia during the exercise testing or recovery. That is ST segment depression is less than 2 mm from the baseline. Okay, in the ECG, we don't consider less than 2 mm as a significant. So that is why they have said that is a silent ischemia. Okay, and the functional capacity is less than 5 minutes. That is the first stage of Bruce protocol. The patient is just able to clear the first stage of Bruce protocol. So these are the exercise testing findings. Okay, so whichever patient is having the or clearing second stage of Bruce protocol with normal hemodynamic parameters, it is classified as low risk. Then moderate risk, if he is able to just clear one first stage of Bruce protocol, that means the patient is in with normal hemodynamic parameters, then he is at moderate risk. And non-exercise testing findings, ejection fraction is of 40% and 49% at rest. Okay, that is by echocardiography. Now in high risk category, the patient is not even able to complete the first stage of Bruce protocol, and there are all abnormal findings in the ECG and the heart rate and the blood pressure. Okay, the complex ventricular arrhythmias are present. Okay, there is unusual shortness of breath, lightheadedness, dizziness. Okay, at low levels of exertion or during the recovery. Okay, the ST segment depression is more than 2 mm. Okay, presence of abnormal hemodynamics, as I said. Okay, the heart rate will fall with the increasing intensity of exercise, or the systolic blood pressure will fall with increasing intensity of exercise. Okay, severe post-exercise hypotension. So all these points, okay, will classify the patient into a high risk category. Then you need to be very cautious while prescribing exercise, or you need to be you should wait for your patient to stabilize medically and then progress with exercise prescription. Okay, so non-exercise testing findings, ejection fraction is less than 40%. Okay, presence of congestive cardiac failure. So you have to wait for the patient to stabilize. If the patient is in high risk, do not hurry up with prescription exercise. You can definitely go ahead with moderate and low risk patients. That is why I said every cardiopulmonary patient coming to you, definitely you should do risk stratification. Okay. So now after risk stratification, we have to do a submaximal exercise test. There are numerous options available in the literature of submaximal testing, but the best studied and across the globe which is used is 6-minute walk test. And there are standard ATS guidelines available how to perform 6-minute walk test. So I'll just brief you what all important things you should note down while performing a 6-minute walk test. So the resting at rest or just before the test, you should note down resting heart rate, blood pressure, respiratory rate, SpO2, and rating of perceived exertion. Rating of perceived exertion is very important. You need to print the box scale, colored box scale on a A4 size paper, stick it on a hardboard and show it to your patient and teach them how to rate their rating of perceived exertion. Okay, it is a 6 to, I have a box scale in my presentation. I'm going to show it. I'll just show it right away. Okay, so this is the box scale. There are two box scale. One is the 6 to 20 box scale and one is 0 to 10 box scale. Okay, 6 to 20 box scale is used with the cardiac patients, and this modified RP scale, that is 0 to 10, is used with pulmonary or shortness of breath patients. Okay, usually. So these are the exertion feeling what the patient will feel. For example, patient says no exertion, or patient is sitting, I'm fine, there is no exertion at all. That means he's going to rate it at 6. Or and the next is if he is standing up and walking a block or 100 yard, and so his exertion lies between 7 and 8. Okay, and then he starts little harder, he's exercising little more with a more speed, then the BOG rating lies between 10 to 12. And aware of breathing harder, that means you're feeling some exertion, that means it is 13 and 14. Okay, and starting to breathe hard and get uncomfortable, that is 16 to 17. Okay, so this is how the corresponding rating of box scale, and there is percentage of heart rate max. So that means if you say 13 to 14, okay, if you say 13 to 14, that means the percentage of heart rate max is 70 to 80, 70% to 80%. So we will discuss this in detail, but I just wanted you all to get oriented to the box scale. Okay. Sorry. Yeah. So you need to ask the patient at rest, are you feeling, how are you feeling? So he may rate it 6, but sometimes the patients are so deteriorated by with their cardiopulmonary status, they are exerting at rest also. So they may rate it very light or hard. Okay. So taking RP at rest is very important. Okay. Then during the 6-minute walk test, you need to ask the patient to walk between the two cones, which is placed 15 meters or 30 meters apart. Okay, they have to walk around those two cones for 6 minutes. Okay, during if you have a heart rate monitor, take the heart rate, SpO2 and RP scale during the 6-minute walk test, and post heart rate, blood pressure, respiratory rate, SpO2 and RP during the post, means during the recovery. Then also you have to note down 6-minute walk distance, how much distance he has walked in 6 minutes. That will guide you to prescribe exercise. Okay, then if the patient has taken pauses, for example, patient walks for 1 minute and says, I am too breathless, I cannot walk. So you need to note down how many pauses he has taken. The duration of the pause has to be included in the 6 minute. Okay, and the cause of the pause has to be noted down. Right. So this is how you have to take the 6-minute walk test. And this is the hallway of 6-minute walk test. You can see two cones, and it is kept 30 meters apart. Okay, if you don't have a place, you can keep it 15 meters apart also. That is not a problem. The standard ATS guidelines is 100-meter hallway. Okay, sorry, 100 feet hallway. So the patient has to start and walk around the cone and then come back for 6 minutes. Okay. So again, you have to also calculate the HR max and target heart rate. and which is very easy. Okay, HR max is 220 minus age. There are other formulas also. Recently, you can take that, but I think this is the simplest one and also easy to remember. There is not much of difference between the recent formula and this old one. Okay, so example for the patient is a 40-year-old male, then the heart rate max become 172. Okay, then you need to calculate heart rate reserve. So the formula for heart rate reserve is HR max minus HR rest. Okay, so that is consider heart rate rest as 72 beats per minute. So your heart rate reserve becomes 100 beats per minute. Then you calculate target heart rate range. Okay, so generally we prescribe exercise from 60% to 80% of heart rate reserve. Okay, that is what we call it as Carbonen's formula. Okay, plus heart rate at rest. So 60% is 0.6 into 100, that is 100 is your heart rate reserve, plus heart rate at rest, that becomes 132 beats per minute, and 80% is 0.8 into 100 plus 72, that becomes 152 beats per minute. So the corresponding rating of RP scale is 13 to 15. Okay, one more important thing is, if you multiply these numbers, the 6 to 20 box scale, if you multiply these numbers by 10, you get the exercise heart rate. Okay, so if you're feeling no exertion, your exercise heart rate is around 60. Okay, if you say that I'm aware of the breathing, harder, more difficult to hold conversation, or for example, you are not able to talk while exercising, that means your heart rate is between 130 to 140. You have to just multiply this numbers by 10 to get an exercise heart rate. Okay, so here if you have calculated 132 by 152, that is 60 to 80% of your heart rate reserve, then the corresponding rating will be 13 to 15. Okay, that means you ask your patient to exercise between these two feelings, that is, he's aware of his breathing, more difficult to hold a conversation. Okay, and starting to breathe harder and get uncomfortable. We don't have to reach here till 80, we have to just be here. Okay, so 13 to 14, that is why the box scale is important. You need to monitor. We can always calculate this range, but only with the box scale you are able to modulate the exercise intensity. That is the reason the box scale is very important. Okay, so I hope you all have understood the use of box scale in exercise prescription. Okay, so this is how you calculate. You have to just calculate this, keep it ready, perform a 6-minute walk test. Okay, note down the corresponding RP rating, teach the RP scale to the patient, how to use RP scale. Okay, very important for you to teach the patient that you should not be reaching that extremely hard and maximal exertion. And even 17, rating 17, if they are reaching this during their exercise, that means they need to slow down. Okay, and if they are in this zone, very light zone, that means they have to increase the intensity. Okay, so the patient should always remember the box scale, or you have to place it a brick printed copy around the treadmill or the cycle ergometer, the printed copy of box scale, so that the patient can continuously rate their exertion during the exercise. Okay, so you need to take box scale whenever patient comes to your clinic during the exercise and while patient is going back or finish the exercise and going back to their home from your clinic. So box scale is a very important tool to modulate, to prescribe the exercise and also to modulate. Okay, the corresponding feeling also gives you the target heart rate range. Okay, right. Now the interpretation of the 6-minute walk test. For example, your patient has walked for 450 meters. So you note down the 6-minute walk distance. Okay, note down the RP before, during the test and during the recovery. Heart rate, SpO2 and RP before, during the test and during the recovery. Blood pressure before, during and recovery. If there is a pause, note down the pause, cause of the pause and the duration of the pause. Okay, assess the, basically we are assessing here the hemodynamic response of the exercise, okay, to the of the cardiopulmonary system. Okay, so this is how you have to interpret a 6-minute walk test. All these parameters you have to write, and based on these assessment you are going to prescribe the exercise. Okay, I hope the role of the box scale and the 6-minute walk test is clear. Anyone is having any doubt, you can ask me at the end of the session. I'll be happy to answer. Okay, then again, whenever you talk about the exercise prescription, it is just not about the exercise, aerobic exercise. When we talk about fitness, it comes the upper limb strength training, the lower limb strength training, the aerobic exercise and the flexibility. And the recent parameter of fitness is also a balance. So you need to prescribe balance exercise to your patients also. Okay, so the assessment for upper limb unsupported exercises, that is unsupported upper limb exercise test, ULEX. Okay, so what you need to do is you need to stick the strips, okay, on the wall at the this thing distance of 15 centimeters. You can see 0 centimeter, 15 centimeter, 30 centimeter, 45 centimeter, 60, 75 and 90. Okay, the 0 should come just above the patient's knee. Okay, and the patient will hold a wand with both the hands, okay, or a rod with a weight of 0.5 kg. Okay, the first is 0.5 kg, as you can see here. Okay, and hold it at the 0 position for 1 minute. If the patient is able to hold for 1 minute with no symptoms of breathless, or he is not reaching any target heart rate range, then go to the next 15 centimeter range for next 1 minute. Again, if he clears, go to 30. Again, if he clears, go to 40. Again, if he clears this for 1 minute, go to 60. And at the 60, if he starts feeling any symptoms or he is unable to go to 75, this becomes the maximum for that patient of upper limb unsupported exercise. So you need to give him exercise till the 60 centimeters, holding on for 1 minute at every 15 centimeters of duration. Okay, or if he clears till 90, increase the wand weight by 1 kg. Again, if he clears, increase the wand weight by 1.5 kg. And you need to stop if the patient reaches, or if there is ST segment depression, or he reaches the target heart rate range, or there is drop in the SpO2. Basically, this test is for COPD patients and patients using more of accessory muscles for their breathing. Okay, so ULEX is the name of the test, unsupported upper limb exercise test. Okay, then there is lower limb strength test, sit to stand. Very simple. Just take a chair, preferably of 48 centimeter height. Okay, chair to be placed against the wall, arm to be crossed over the chest. Allow one sit to stand for practice instruction. Stand up and sit down as quickly as possible for 5 times. Keep your arms folded across your chest. Measurement, you have to just note the time, how much time the patient is taken for doing 5 sit to stand. Okay, that will give you a global idea of strength of a lower limb. Okay, you can perform this test before you start lower limb strengthening to the patient. Okay, so I think the assessment is clear. The lower limb strength test, the upper limb strength test, the 6-minute walk test, the stratification, the family history, the medical history, okay, the drug history, even the exercise history has to be noted down. Okay, once your assessment is done, then you come down to the exercise prescription part. Okay, so how to prescribe exercise based on this assessment? So as I said, you need to prescribe aerobic exercise. You need to prescribe the upper limb training, unsupported upper limb training, mostly in COPD and patients who are using accessory muscles of breathing. Okay, then the upper limb strength training and the lower limb strength training. Okay, so these are the 4 components or the 4 parts of your exercise training. Okay, so based on the 6-minute walk test or 6-minute walk distance. So consider this patient has walked for 324 meters in 6 minutes. So how do you prescribe a walking program? Okay, so walking program, if he has walked 324 meters in 6 minutes, so how much he will walk in 10 minutes? Okay, do a cross multiplication and take a 80% of that. Okay, I'll repeat. Patient has walked for 324 meters in 6 minutes. So just do a cross multiplication and calculate how much he will walk in 10 minutes and take a 80% of that, that is 432 meters. Okay, so you got how much you need to make your patient walk in 10 minutes. Okay, and you can also convert it into lap. Okay, just divide this by 30 meters because you have a 6-minute lap of 30 meters. So divide this by 30, you get 14 laps. So you tell the patient, you take a 10 minutes of time and walk 14 laps with a 30 meter of distance. Okay, so this is the initial program you start with, which is risk free. You don't have to take any risk or hurry up in prescribing exercise. This is the initial stimulus, as I said in the one of the first systematic
Excuse me,
review,
Pooja.
that
Pooja, Parith, mute yourself.
as I initially said, that just little amount of increase in the physical activity can reduce the mortality rate and reduce the disability in the patient with cardiopulmonary patient. So it is as simple. You have to just do a simple maths based on your 6-minute walk distance. Okay, if he's walking for 324 meters in 6 minutes, multiplied by cross multiplied by 10 and take the 80% of that, that is 432. And if you want how many laps he should walk, divided by 30 and ask your patient to walk for 14 laps in 10 minutes. Okay, then for example, if you don't want to give a walking program, or the patient is suffering from some locomotor disability or knee pain or leg pain, you want to give a cycling program. So ask your patient to maintain a box scale of 11 to 13. Okay, 11 to 13, that is fairly light to somewhat hard, for 10 minutes and progress to 15 minutes. Here also you can progress to 15 minutes after the next week. Okay, and do not forget to prescribe warm up and cool down. So 10 minutes or 15 minutes of walking or cycling program, and 10 minutes of walking warm up, and 10 minutes of cool down additional. Okay, in this consider low intensity exercise or flexibility exercise. So this is how you're going to prescribe the exercise scientifically based on your assessment. Okay, you can also calculate the treadmill speed if you want. Okay, because you got the distance and you have the time, so you calculate the speed, and based on that you set the treadmill speed. Okay, then these components: mode, intensity, duration, and frequency. So you have to write down this in your prescription form, that mode you have selected is walking, cycling, etc. Okay, intensity of the box scale is 11 to 13. Okay, and even if you have taken the heart rate reserve range or target heart rate or Caron's formula, write that target heart rate range also over here. Okay, duration is 10 minutes, progress to 30 minutes. Frequency is 3 to 4 times a week. You don't have to prescribe aerobic exercise all days a week. It is always 3 to 4 times a week, and rest 2 days you have to give them upper limb and lower limb strength training. Okay, so I hope the aerobic exercise part is clear now. The upper limb training based on your UULEX test. Okay, you should start with a 0.5 kg of band, holding for 1 minute in every step with coordinated breathing. This is very important. Patients just hold their breathing during the upper limb training and they desaturate. Okay, so coordinated breathing, you need to tell them to breathe in and breathe out, or do pulse breathing if it is a COPD patient. Okay, go to the next step vertically every minute. Okay, so the mode is upper limb exercise with wand. Intensity, again, you can modulate it with 11 to 13. Duration based on the UULEX test. Okay, and frequency 2 times a week. So the other days when you're not prescribing aerobic exercise, do go ahead with upper limb training. Okay, or upper limb strength training or lower limb strength training. Okay, and upper limb strength training based on the upper limb strength assessment, and lower limb strength training based on the lower limb strength assessment. So basically we have to prescribe 50 to 60% of the 10 RM. Okay, so calculating 10 RM or 1 RM, theoretically you can do it, ask the patient to do maximum weight what he can lift for 10 times. But clinically what you can do is, any weight your patient is able to lift for 12 repetitions easily, okay, then shift to the higher weight. Okay, that becomes the RM. Okay, 10 RM. If your patient is able to lift 5 kgs 12 times, that means 5 kgs is good enough. Go to 6 kgs. Okay, and if he is not able to lift 6 kgs, then the 5 kgs becomes the 10 RM. Okay, so use free weights or therabands. You can select 3 major muscles in the upper limb, that is biceps, triceps, and deltoid. 10 reps and 2 to 3 sets of all these muscles. Okay, mode again theraband, free weights, intensity 50 to 60% of the 10 RM or RPE 11 to 13. Repetition, you can have 10 to 12 reps and 2 to 3 sets, frequency 2 times a week. Similarly, you can just select 3 muscles of the lower limb, that is quadriceps, hamstring, and hip abductors or hip extensors, whatever the patient is comfortable with, or based on his activity of daily living assessment. Okay, then the same weight cup therabands, intensity 50 to 60% of 10 RM or 11 to 13 RPE, repetition 10 to 12 repetition or 2 to 3 sets. Okay, and frequency 2 times a week. So this chart gives you a holistic approach of scientific exercise prescription. Okay, aerobic exercise, upper limb unsupported training, upper limb strength training, and lower limb strength training. Okay, you can also add balance exercises if you want, okay, based on the assessment of the patient, right? The monitoring part is very important to avoid any untoward events. So before, during, and after the exercise session, do monitor heart rate, BP, and RP of the patient. Okay, if you think that the heart rate is shooting above the target heart rate range, okay, then you need to reduce the intensity then and there. Similarly with the blood pressure or with the RPE, or if the heart rate is not shooting up or the RPE is very low, then definitely you have to increase the intensity of the exercise. Be cautious if the patient is on beta blocker. Do not believe on heart rate monitoring during the exercise, because the patient is on beta blocker, the heart rate response will be blunted. Okay, so you have to modulate with the RPE if the patient is on beta blocker. Okay, the special consideration for COVID-19 patient. So what my experience says is, do not give overload stimulant till the patient oxygen saturation is not stabilized. Okay, if the oxygen saturation is less than 94%, do not give overload stimulus, but you can still mobilize the patient with or without O2 depending on the saturation of the patient. Breathing exercise and coordinated breathing with the activities plays a major role in weaning off from O2. Okay, whenever you're mobilizing the patient, ask the patient to coordinate the breathing. Okay, inspiration and expiration properly, then definitely you will see a greater improvement in the patient of COVID-19. Okay, so coordination of breathing with the activity is very important, and it will help you to wean the patient from O2 earlier. Okay, so these are the special consideration for COVID-19 patient. Do not touch the patient if the oxygen saturation is less than 92, because the lungs are still immature or it has not recovered from the injury. Okay, similarly, for example, at least wait for 4 to 6 weeks, or maybe 3 to 4 weeks for the lungs to recover. And then if the oxygen saturation is normal, then give the overload stimulus to the patient. So the take home message, take the medical history, exercise history, the stratification, do a submaximal exercise testing, upper limb and lower limb strength assessment, and give a proper structured exercise program and monitor it. Okay, so I think that's all from my side. Thank you so much. I really thank Team AIMS for organizing this webinar, and I also wish happy World Physiotherapy Day to all of you. So these are my contact details. If you have any doubt, you can get in touch with me in any of these. Thank you so much. Thank you, Alapa ma'am. Over to you.
Thank you so much, sir, for the wonderful session. This is Hardini ma'am. Sir, I just had one doubt. Yes, not exactly the doubt. I just wanted to ask the box wala side, in which you told, right, that every time we just have to multiply by 10. Yes. That will give you the target heart rate.
Exercise heart rate. Yes.
Sorry, exercise heart rate. Yes. Sir, is there any reference for that?
Yes, there are a lot of studies. It has been studied on the exercise labs, and it is proven. And you can have guidelines of ACSM, American College of Sports Medicine, even American Heart Association, or American Association of Cardiovascular and Pulmonary Rehab. So all of them, they recommend this, and it has been proved. So if you want, I'll mail you the article.
Sure, sir. Thank you so much. And even, sir, in the next slide, next slide, which was like showing the exercise prescription, na?
This one?
Exercise prescription.
This one?
This one, right? Yes. In this, the walking program, 324, the example which you have given in this, multiplied by 80%. So every time you have to keep it 80% only?
No, you can start with 60% also, madam, based on the excess capacity of the patient. Or the risk study. If the patient is of high risk, then you can start with 60% or 50%. And then
and distance also, sir, this time duration also, like here you have mentioned 10 minutes. So if patient is not even able to walk for 10 minutes, and if I keep it at 8 minutes, will it be fine?
Yes. These are just an example. You have to act according to the patient. Definitely, you are very right, madam.
Fine. So ultimately, we have to look at the box scale, which you have discussed.
Yes. Box scale is a very important tool. You can also convert it into the local language, the feelings, and then definitely you can paste it on your clinic. And
Okay, sir. Got you. Rutvi, will you please mute? And from the student side, any other doubts or queries?
Yes, ma'am. Sorry, ma'am.
Any doubts for the students? Any doubts from students? Anyone have any doubts in any cardiovascular and respiratory physiotherapy, you can get in touch with me anytime. I'll be happy to help.
I think I don't think any doubts, sir. But it was a wonderful session. We enjoyed thoroughly, sir.
Thank you.
Really, there was like the few things were actually new to even for me also.
Thank you.
So it was really a nice session. Thank you so much, sir. And we will like to hear you more and more futurely.
Sure,
In future, even we can have a more conversation and we can keep such lectures for students, especially the PG students.
Definitely, ma'am. Definitely. I'll
So,
be happy to share my knowledge.
So I will be in touch with you, sir.
Yes,
Fine.
Yes.
And thank you from the whole AIMS family, sir, once again.
Thank you, sir.
And wishing you the wonderful life and wonderful career. Okay.
Thank you, ma'am.
All the best, sir. Okay.
Thank
So
you.
I think we shall stop now.
Thank you, ma'am. Thank you so much. Thank you, everyone. Thank you, all the participants, for your patient listening. Thank you, everyone. Thank you, teammates.
Okay, sir. Goodbye, sir.
Goodbye. Goodbye.